Hello. It's an honor to be here today to be able to summarize at the end of the CODA study. We started planning this trial nearly 7 years ago and never could have envisioned at that time that we would expand to a team of over 25 sites and over 150 investigators, nor that we would have ended in the beginning of a global pandemic. But then we had the opportunity to contribute to science that was rapidly so important for the care of emergency general surgery patients. I want to start with gratitude for you all in engaging in important discussions, your thoughtful criticisms, and the amplifying of lessons learned from the participants in this trial. On January 21st, the first COVID patient was identified in the United States in Washington State. And just a few weeks later, CODA enrolled our last patient, the 1,552nd patient into the trial. While the recruitment was done, we had planned to let the data bake over the course of the following year. But at the time, there was a lot of uncertainty, with operating rooms across the world being limited to preserve PPE, and in some cases, to maintain space for critically ill patients. Questions were coming to us about the best decisions for treatment options, and I want to take a moment to recognize the amazing team that we were able to work with. We made the decision to open the data and rapidly work towards an early analysis and early results of 90 days because the pandemic had supercharged the question about healthcare utilization and the safety of antibiotic treatment in this incredibly common emergency general surgery diagnosis. This was taken on by clinical teams, many of whom were redeployed to COVID ICUs. And many of our clinical teammates, our research teammates, and our biostats team were juggling sick loved ones and the homeschooling of their children. In reflection of this past 18 months, I'm incredibly proud of how this team has come together. I'd like to jump in, though, with the limitations of the study. Appendectomy for recurrence is likely to increase with longer-term follow-up. This is a pragmatic trial. The technique was not standardized. Imaging in the emergency department could be ultrasound or it could be CT scan. Surgeons could choose lap or open options for surgery. And the indications for appendectomy in the antibiotic arm, our surgical teams were all coached in the best treatment practices for keeping patients in their treatment arm. But as in all ethical trials, as surgeons, our responsibility is to the person we are treating. And we would expect there to be some variability when the decision was made to switch and operate rather than to continue on antibiotics. A novel aspect of the pragmatic trial design were that patients were able to be discharged when they met discharge criteria. That is, it could be from the PACU immediately following surgery. It was when they were able to take in adequate pain medication orally, they were able to tolerate a diet, and able to manage their medications. And some patients were able to be discharged then from the emergency department when randomized to antibiotics. However, this was a strategy that was variably used, with some sites frequently discharging from the emergency department and some sites never discharging from the emergency department. So the hospital process really played in, rather than just patient acuity, in determining how long patients stayed within the healthcare system. Patients' reported quality of life outcome is incredibly important to some people, but not the most important outcome to everybody. We lacked blinding in the trial, and while we under-recruited females within this trial. Secondary analysis should be considered exploratory. For the endpoint of recurrence, there is no established window for resolution of index appendicitis, and there is no biological basis for selecting a 30-day cutoff. Pathology reports were used to confirm the recurrence of appendicitis rather than laboratory, radiographic, or operative findings. And these were not standardized across sites, and they were not available in 10% of participants. Those with an additional course of antibiotics who did not have an appendectomy were not included in the rate of recurrence because the diagnosis of appendicitis could not be confirmed. Elapsed time between an appendectomy and surveys about the reasons for an appendectomy may have resulted in recall bias. And data was missing at non-trivial rates and not necessarily missing at random. We addressed this by including all confirmed cases of appendectomy in the Kaplan-Meier analysis, and we performed a sensitivity analysis of recurrence, including those with histologic evidence of appendicitis. We used a weighted cohort to calculate the risk differences and found similar results in the crude analysis. However, the risk of a type 2 error is possible, especially given the low rate of certain events, and we did not adjust for multiple testing or for center effect. Subgroup analysis related to recurrence was not planned a priori. CODA is the largest trial to date on appendicitis and includes historically at-risk patients, both those with appendicolith, those with perforation, to try to capture the broadest range of disease severity for the patients that we see. Approximately 3 in 10 patients undergo appendectomy, and 4 in 10 in the appendicolith group had an appendectomy. After 30 days, there was approximately 3 in 10 patients that had an appendectomy, with 95% pathology confirmed. Appendicolith was not associated in these longer-term outcomes, and diameter greater than 10 millimeters does appear to be associated. And this grew to nearly 5 in 10 by 3 years. There are multiple outcomes that favor one treatment option or the other, and decision makers really must weigh the characteristics, the preferences, and the circumstances. There's a role for antibiotics, or there's a role for antibiotics. It's probably a good choice for some, but not all. And this leads us to a discussion about shared decision-making. There is no agreement about a single outcome measure or an acceptable threshold of the risk of recurrence or need for appendectomy that would make antibiotics or appendectomy a desired treatment option for every patient. A discussion of treatment risks, benefits, and eliciting patient preferences and priorities are really the cornerstone of shared decision-making and can improve both outcomes and patient experience. A key component to shared decision-making is understanding personalized risk. In CODA, either because of biologic reasons or surgeon patient preference or bias, those with radiographic evidence of appendicolith had a greater likelihood of appendectomy during the initial episode. However, this increased risk was attenuated by 30 days. Shared decision-making is more common in elective practice, and we would argue is critical as well in our emergency general surgery patients, especially given there's often less opportunity to consider preferences or to plan for things like work and school and caregiving opportunities or caregiving responsibilities. Whether a relative increase in the rate of appendectomy is important to patients considering antibiotics is really unclear. Patient advisors engaged in planning CODA reported that they would find an appendectomy rate of greater than 75% acceptable for those people, given the goal of avoiding an urgent surgery. Testing this more formally, a recent survey study asked 1,257 people about their preferences about antibiotics for appendicitis, varying only in the description of the rate of eventual appendectomy between 10 and 60%. Across all proposed rates of appendectomy, greater than 75% of those surveyed were willing to try antibiotics, and more than half reported willing to try at any rate. While some clinicians may find these rates of appendectomy to simply be unacceptable, there are conditions where it's common for patients to select less invasive treatments, even if there's a probability that surgery may ultimately be needed. For these reasons, we believe patients with appendicitis, including those with an appendicolith, should be appropriately informed about both treatment options as part of a shared decision-making process. As Dr. Thompson mentioned, Dr. Jacobs provided a really thoughtful editorial highlighting ongoing healthcare disparities within the United States. Appendicitis management is not just about clinical disease severity, but it also includes the intersection of socioeconomic determinants and the structural biases within our healthcare system that are driven by systemic racism and impact both health and health outcomes. Our recommendations and our patient decisions are not made in a clinical disease severity vacuum. We have to give consideration for measuring success with a lens towards equity and health justice. In our US fee-for-service healthcare system, we are rewarded far more for doing procedures than we are for discussing treatment options with patients. Furthermore, financial incentives promote progressive inequity if left unchecked. It is on all of us to consider the impact of treatment we recommend and for whom we recommend that to ensure those who have been historically and continue to be marginalized in our health system have the same opportunity of recovering from their emergency general surgery disease. We used throughout the study a standardized video that was led with development by Dr. Jonathan Kohler to ensure that every patient approached had the same information about appendicitis, what we knew about different treatment options, what we know to date, and what it means to be part of an RCT. When CODA stopped, we recognized that that was a phenomenal tool. And we're now growing that tool online, available in a website called appyournot.org. We're planning to expand this work into an implementation program called Triad that shares the same goals of giving patients critical information about appendicitis. This is surgeon-led. It focuses on safety, using available evidence, and the goal is really to empower patient choice for patients that are appropriate to consider both treatment options. We appreciate the collaborations partnering in this work to date and anticipate launching in the following year. I'd like to acknowledge our funding agencies, PCORI, NIH through NIDDK T32 training grant, and ARC for the certain infrastructure. I'd like to thank Dr. Pham for your leadership in leading this trial, your vision in launching a trial that was pragmatic, that included the broadest range of patients, and that was inclusive to recruit this large heterogeneous group, but also in collaborating with other clinical researchers and ensuring that there was room at the table for various ideas. We're incredibly grateful for the Patient Advisory Board and the leadership of Bonnie Bazell, who chaired this work, as well as our National Advisory Board. I thank you to Dr. Lavallee and Sarah Lawrence, who led the stakeholder community, and to Dr. Haggerty and his team at the DCC, especially our lead biostatistician, Sarah Monsell, and the incredible work of the DSMB. And importantly, we could have never accomplished this work across our 25 sites without the leadership of Erin Kearney-Fannin, who led our research team. Congratulations to the collaborating teams across 25 hospitals in the US. The leadership and the collaboration of these individuals at each of their home sites is the reason for the trial's success in meeting our recruitment goals. And we are especially appreciative of the generosity and the altruism of all the participants who participated in this trial. Thank you for your time today.